Okay, time for You Make the Call. This is where I show you one slide with two images, and we discuss what this likely is, and then we look at the answer and we see how well we did. So again, it's a challenge because you only will see two images, and I apologize, there's a little bit of history, but I want to leave it where you think about the case. You come up with a differential diagnosis. Sometimes you'll be right, and sometimes you'll be wrong. Sometimes you'll be right for the wrong reason, and sometimes you'll be wrong for the right reason. Anyway, here we go. This patient has abdominal pain, and you see a mass in the root of the mesentery. The mass has dense, coarse calcifications. Now, there's three things I think about. One is carcinoid tumors. They often have, in about 70% of cases, desmoplastic reaction and calcification. We think about sclerosing mesenteritis, which also probably in the 70 to 80% of the time will have coarse calcifications. And in theory, I would need to think about a patient with lymphoma who's had radiation therapy, potentially radiation and chemotherapy, and the nodes in part calcify. Well, there's nothing else here that makes me think about lymphoma, and that's pretty rare. So really, I'm stuck with carcinoid versus sclerosing mesenteritis. Now, if you had more images, you want to look at the vessels. Encasement of the SMA is more common, as well as SMV with carcinoid tumor. Also, perhaps you may see an additional finding like a mass in the terminal ileum that's vascular, which is the primary carcinoid tumor. If you only see the mass in the mesentery and you don't see much of a desmoplastic reaction, you're probably going to push yourself to sclerosing mesenteritis, particularly when it's an incidental finding, as was for the most part the case here. And this was sclerosing mesenteritis. A really nice example, and again, it could be challenging. You could do a biopsy, but what if the biopsy comes back negative? Then you're kind of stuck. People have used dotatate scans at times because dotatate is about 90% of the time positive if you have a neuroendocrine tumor. So if it's negative, you're more likely, not 100% specific, but you're more likely to be dealing with sclerosing mesenteritis. A really nice case. This patient has abdominal pain and there's a large solid mass in the left upper quadrant. Now, one of the challenges only seeing these images is that I could be dealing with a large adrenal tumor, like an adrenal carcinoma. I could be dealing, though not the greatest likelihood, of a large mass in the tail of the pancreas, like a SPEN tumor, or maybe a neuroendocrine tumor. That's a possibility. You could be dealing with a retroperitoneal sarcoma, which is growing upward. That's a definite possibility. This lesion is really well defined and probably involves or arises from the stomach, which is best seen on the image on the right. So one of the things I need to think about is a primary gastric lesion. This is not going to be the look of adenocarcinoma. It's not going to be the look of lymphoma. It's the look of a GIST tumor. GIST tumors are typically exophytic. Sometimes they're intraluminal. Sometimes they're exophytic and intraluminal. They can be very large. And again, it can be somewhat of a challenge. You need to make sure you're not dealing with pancreas, retroperitoneal masses, or typically an adrenal mass. And in this case, this patient had abdominal pain, but the pain was more right-sided. This finding was almost maybe incidental, though probably not. The patient probably had some symptoms, and this was a GIST tumor. Remember, gastric GIST tumors can be somewhat vascular. GIST tumors in general, about 30% occur in the stomach. When they occur in small bowel, the smaller lesions are typically hypervascular. The larger lesions are typically relatively hypovascular and can have areas of necrosis. So a real nice example of a gastric GIST tumor. This patient has weight loss and fever. When you look at the images, what I see most is this pattern which looks to me like carcinomatosis on the omentum. When I see carcinomatosis, I think about, well, if it's a female, especially ovarian cancer, it could be a mesothelioma, could be gastric cancer, could be colon cancer. There are a number of tumors that commonly give omental caking. Now, the patient has fever, but patients with malignancies often do have fever. I was once shown a case like this in conference, and they told me the patient was from Ethiopia. That didn't quite help me. Maybe it should have. The one thing that can look like carcinomatosis with omental caking is tuberculosis. So one of the things, if you have a patient where the history of malignancy doesn't quite fit in, and the patient has fever, and the patient comes from a country, particularly in Africa, the thought is perhaps it's TB peritonitis. And in fact, this case was TB peritonitis. Just a really nice example. Again, 99% of the time, I'm just going to say carcinomatosis and not really think about it. But it does make the point that carcinomatosis and TB peritonitis with this omental appearance can look similar. What an unusual case, but what really is a great case. This patient has right lower quadrant pain. There looks like a process involving the terminal ileum as well as the cecum. There also is the suggestion of nodes. So what am I thinking about? The first thing I think about is malignancy. So you could think about a carcinoid tumor of a terminal ileum involving the cecum. You could think about a colon cancer involving the terminal ileum. You could think about lymphoma. We mentioned that all of the time. Nodes, involvement of ileum, involvement of the right colon, including cecum. We also could think of inflammatory disease. Could this be Crohn's disease? Crohn's commonly involves the terminal ileum and can extend into the cecum and ileocecal valve. But again, Crohn's is usually more of narrowing. Here it looks more mass-like. I did see a case recently that was IG4 disease, which looked like a malignancy. So if everything else was negative, I might consider IG4 disease. Again, in terms of the differential in your mind, you think of tumor, then you think of inflammatory disease. You know, we talk about inflammatory disease in the right lower quadrant, particularly in the summer. Patients get salmonella infection. You can have Shigella infection. Those are pretty rare, but can occur with the right history, particularly in younger patients with no other signs of malignancy. This patient was worked up further, and this ended up being salmonella infection. Again, I'm still looking at this without much of a history. I'm still concerned about malignancy. Again, I tend to favor lymphoma first, maybe carcinoid second. But with the right history, salmonella infection typically involves the ileum, can extend into the cecum, can have nodes, and can be a great mimicker. And this was really just a terrific case. This patient has acute abdomen, and what you notice is ascites, but also this impressive thickening of jejunum. It really is edematous folds with prominent mucosal enhancement. It looks like edematous folds. So you could think about, could this be tumor like lymphoma? Could it be some other tumor? That's a thought. Could it be an ischemic bowel? The vessels look okay on the images we see, but ischemia is still going to be a definite possibility in this case. And when you start thinking about strange things, you can talk about graft versus host disease, but that's usually terminal ileum and you have a history. But it is a possibility when I'm showing you two images. When I use the word angioedema, and I said it looks like edematous folds, you also need to think about medications, patients on chemotherapy, but patients who are given ACE inhibitors are something you also need to think about, particularly if the patient recently had new meds from their cardiologist and present to the ER with acute pain. And in this case, that's what it was. The patient went to their cardiologist. They started medication about a day earlier. Patients can have severe reactions to ACE inhibitors, marked bowel wall thickening, really impressive, an impressive acute abdomen. If you can suggest the diagnosis and the history matches, the treatment is stop the medication and the patients get better in 24 to 36 hours. You would hate to have this patient go to surgery for ischemic bowel. Again, ischemia is a consideration, but the vessels look so good, it was not going to be what we were thinking of. And just a couple slides. Angioedema is a clinical description of inflammation-mediated edema in the dermis or subcutaneous tissues, can involve the skin, the respiratory tract, or GI tract, and if medications are stopped, it resolves typically within 24 hours. And the pathophysiology is interesting. It can be allergic or kinin-induced, ACE inhibitors. Again, angioedema is the thing you worry about, and it's potentially a really difficult diagnosis. This patient has abdominal pain, and you see a mass in the region of the left adrenal bed. And yes, I want to make sure it's not coming off the stomach like a GIST tumor. I want to make sure it's not coming off the tail of the pancreas. I want to make sure it's not a retroperitoneal mass proper. But I think on the epicenter, again, 2 images, that's not going to be a real study, but I'm going with adrenal. Adrenal mass, you could think of things like pheochromocytoma. They're not always vascular. You could think about almost any tumor that bled. But the first thing I would think of was a primary adrenal cortical carcinoma. They're often large, they can be necrotic, they can be slightly vascular, they can have calcifications occasionally, but they can present when they're large. Typically the patients have no hormonal abnormalities. The most common presentation, of course, is Cushing's, and those tumors are picked up when they're smaller because of the clinical presentation. And in this case, it was a schwannoma. Yes, I do agree it was adrenal, and I do agree it should be an adrenal cortical carcinoma. We've seen a handful of schwannomas. They're often small. They can be large, as in this case. We think about neurogenic tumors as low CT attenuation, and that could be helpful, but I have to admit here, I'm looking at this mass thinking it's simply necrosis. This mass was resected. It's a benign tumor. The patient did great. Again, this shows the challenge of radiology. It also shows why pathologists exist, because if it was up to radiology, this would have been adrenal cortical carcinoma, but it ended up in the patient's favor, being a schwannoma. This patient has right upper quadrant pain. The lesion is in the region of the right adrenal bed. Yes, you want to make sure it's not coming off the kidney. Yes, you want to make sure it's not coming off the liver. But it looks like it's simply pushing. You would look at the coronal views, maybe the 3D imaging. Now, if this is adrenal, what could it be? The 2 things I think about most would be a necrotic primary adrenal cortical carcinoma. That would be a good thought. The second thing with cystic lesions that are large, that are somewhat vascular, I got to think about a pheochromocytoma. Other unusual large masses, metastasis could be considered. If you had a history, melanoma and hepatoma are the ones that give the biggest masses. You can get vascular masses from renal cell, but the kidneys look okay, and usually the metastases are smaller. Other unusual tumors would be considered, but I'm sticking between pheo and primary ACC. Simply get metanephrine levels. If they're elevated, you're dealing with a pheo. And in this case, it was a pheo. The patient also has a subtle lesion right lobe of liver. There were other images, obviously, in this case, which showed liver metastasis. But remember, that doesn't help me that much because both pheos and ACCs can be metastatic to liver. Remember that pheos are typically benign lesions. 90% of pheos are benign. 10% are going to be malignant. And this was one of those pheos. And the large pheos are often necrotic, somewhat vascular, but it's the smaller pheos that have that marked vascularity. This patient has hematuria, and I'll tell you the patient is 10 years old. Now, when you look, you say, well, could this be adrenal pushing down? And if it was a 10-year-old with an adrenal mass, I would have said a neuroblastoma. But the mass really does look, particularly on the image on the right, like it's coming from the central portion of the kidney. Now, if the patient had sickle cell disease, usually as teenagers, they get these medullary carcinomas. We can occasionally see just a clear cell renal cell carcinoma in kids, though that's pretty rare. When you have a 5 to 10-year-old and you see a large, solid renal mass, or what looks like a renal mass, you better be thinking about a Wilms tumor. Wilms can be necrotic, like in this case. They can be vascular. They can be unilateral or bilateral. They can go to bone. They can go to nodes. This patient's tumor was resected, and this was a Wilms tumor. And this patient was 8 years old at initial presentation. So again, thinking about pediatric tumors, you got to always think about Wilms. Consider the other possibilities, but they are going to be a bit less common. This patient has abdominal pain, but this study, in fact, was really a follow-up study. This patient had a primary tumor. If you look hard, there's clips by the left renal bed. This patient had a prior nephrectomy, which explains why the tail of the pancreas falls posteriorly and the stomach falls posteriorly. There was then an enhancing lesion in the patient's pancreas. If the patient did not have a left nephrectomy, I would look at this and say, this is a neuroendocrine tumor. Neuroendocrine tumors are typically vascular in the pancreas, often don't obstruct the pancreatic duct. That would be a great diagnosis. But here there is a left nephrectomy, which means the patient likely had a renal cell carcinoma, typically a clear cell renal cell carcinoma, and this was metastatic disease to the patient's pancreas. Now you can argue and say, how do I know it's not just a second primary, like a peanut? Well, let's see what the answer is. This was metastasis. Again, in a differential, I would have to admit, I could mention that I can't exclude a neuroendocrine tumor. They can get some lab values. But statistically, when you have a renal cell and there's a recurrent vascular lesion in the pancreas, it's going to be metastatic. Often these lesions are multiple. It's rare to get multiple neuroendocrine tumors. So when you have multiple lesions, it even makes the diagnosis even simpler. This patient has abdominal pain and a large mass in the head of the pancreas. In the little bit of liver you see, you do not see dilated ducts. So you have a large mass. The first question is this really pancreas, or could this be duodenum? That's a thought, and of course with just a couple images it can be difficult. But for argument's sake, I would pick pancreas here. Could it be an adenocarcinoma? That's a possibility, though it is pretty large. And if it was that large, I would have expected to see some duct dilatation. It doesn't look like any of the cystic tumors. There are areas of necrosis, but this is not a serous cystadenoma. This is not going to be a mucinous cystic neoplasm or MCN. If this patient was younger, particularly if they were female, you could think about a SPEN tumor. These papillary epithelial neoplasms or SPEN tumors. They have a range of appearances, can be cystic, can be more solid. And although we typically talk about them being female by a 10-to-1 ratio, and usually being in the teenage to 20 years, we've seen them in both male and females up to and into the 70s. This patient had surgery, and this was a SPEN tumor. Now, I didn't tell you the patient was 26. If I told you it was a 26-year-old female and you had a pancreatic mass, without even looking at the case, I would have said a SPEN tumor. Well, that's it. I've shown you lots of cases. I hope you enjoyed them. I hope you enjoyed the discussion. And I hope you get them right when you see them in clinical practice. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.